The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The opinions and ideas expressed are those of the hosts and guests and do not necessarily represent the views and opinions of any organizations we may be affiliated with. As always, follow your local protocols. Hello, everybody, and welcome to the Medics Musings and Mayhem podcast. We are so glad you're back listening to us. Today, we have a great episode. We have a new co-host guest person, which is fantastic. As always, I'm Phil, joining you from Chicago, and with us, Dr. David Collins, newly minted Dr. Regan Washist, and from the far reaches of North Dakota, Marie Tate. Hi, Marie.
Hello. I'm super excited to be here.
Awesome. That's fantastic. Today's episode is on eye injuries. It's going to be a pretty short one, but it's going to be really impactful, high yield for you. So let's get right into it.
We like to start things off with a case. I had a grab bag of ones from residency era, and I'm going to mix and match a little bit because we're all about de-identifying and all that good stuff. So in a nondescript location, a page goes out to our illustrious medic, Regan Washist, and our other medic, Phil, who are just hanging out, waiting for something awesome to happen. Page goes out asking for a response to an explosion heard at one of the homes in the area.
So already so much running through my head. An explosion can be anything from like a little pop to let's also get fire involved because this house is going down. It's a trauma call. And we know how to run our trauma calls. So we kind of prepare ourselves as we're en route to this scene and just reminding ourselves that we might see some gnarly things, but we keep our cool and we assess the patient as soon as we can get in there safely, always making sure it's safe to enter that scene, especially in cases like explosions.
While you and Phil are discussing this plan and getting into the rig and doors are closing and the radio's crackling, it's a little garbled, as it is out in the middle of nowhere. Something about a pool exploded or a pipe exploded, and law enforcement is just getting there, but it sounds like there was some sort of explosion that happened in a pool or outdoor pool, as best you can tell. Once you get to the scene, you've got people kind of running around everywhere. Lots of chatter, confusion. Neighbors are taking videos and putting it up on their Facebook feeds and all that good stuff because we live in an age like this. Getting to the patient, you find that you have your outdoor pool. I don't know how many people know what outdoor pools look like, so I'm going to describe it a little bit just from my experience. You got your outdoor pool, and then usually there's a little shed or like a little area where there's a series of pipes that filter the water, adjust the pressure, et cetera, et cetera. There's basically, let's not call it a crater, but there's a little bit of a hole in the ground where the pipes were. Patient is sitting up, coughing up blood. You see various debris of plastic pipe in his face, but then when you start talking towards him, you notice that there's a big old piece of plastic just sticking out of his eyeball as he's looking right at you. And as he moves his eyes to the side, it's just kind of moving around. It's very, very disturbing.
Definitely a distracting injury. Usually the first injury that you see on these cases is where most of your attention is going to go to. And that's something that we always have to remind ourselves what else is happening. And so we know that there's some sort of debris that has flown at this person. We can clearly see it in their eye, which is a concerning finding, but what's going to hit them first? What's going to kill them first? And that's where we need to start with assessing, do we have this debris in our airway? Is any of this debris in their neck? Are they able to talk to me? First and foremost, before I start going for this eye.
Phil, what are you doing as Reagan's partner on this one?
Yeah, so scene management on something like this is huge. The ability to assess a patient really quickly. If you're the partner and you have a primary caregiver that's kneeling down next to a patient, just keeping control of everyone around can oftentimes be the difference between a really solid assessment and then one that was, interrupted a few times by people trying to talk and hand them phones and give them information and yell and scream and stuff. So managing the scene is huge there. And also sort of anticipating the needs of my partner. So in the case that Regan is assessing and doing the sort of initial top to bottom of what's going on here, I might want to make sure that the equipment that she might turn around and be like, hey, can you get me X is nearby and ready. there tends to be a little bit of a pause when you're kind of looking at somebody, particularly with a distracting injury, a really extreme one. And you're like, whoa, especially if it's the first time you've seen it. This is where I always bring up running through things in your mind before ever they happen. Have these seminal scenarios in your mind. Imagine yourself in the scenario and then walk through the steps that ideally you would want to make sure you get done. It will help you in the time that you actually come upon this in real life. You'll have a file in your brain to reference. So I always go to that. As a partner, anticipating those needs and managing scenes, so it's great places to start.
Let's transition over to arriving on scene. You're getting your initial set of vital signs and you're getting your brief history. As we've talked about, we're going to follow the same template we always do for these protocol podcasts. Talking to the patient, you don't get a lot because he's very distracted by the fact his face is full of plastic. But the wife tells you that he was getting impatient for the pool repairman to come, so he started futzing with it himself. And then next thing he knew, it blew up in his face. Wife says there was no loss of consciousness. You get him hooked up to the monitor. He is very hypertensive. We'll say he's 180 over 130. Heart rate's in the 120s. O2 sats are about, we'll say 90-ish%. Respers are on the upper end of, mid 20s. And we'll just say for the sake of argument that he's afebrile. So there's your preliminary presentation, your initial vitals. Where do you want to go with that? What are your next steps, Regan and Phil?
Along with getting those initial vitals, that initial assessment, like Phil was saying, I want to know if this guy can talk to me. I can tell that he's breathing because we got those, vitals for that. And a little head to toe. I know there's this injury going on in this eye. And of course, it's natural. It's our human instinct. We're going to keep looking back at that, but really reminding ourselves, just simplify it. Are they hit on the head anywhere? Are they able to talk to me? Are they breathing? Do they have any chest trauma? Is anything penetrating in that abdomen? Can they move their fingers and toes? Just take one little step back and head to toe assess it, because if you're too busy staring at this piece of plastic that keeps moving around with the ocular movements, what if you miss that piece of plastic that hit an artery on the arm and he's actually just bleeding out on the side?
Yeah, absolutely. And, the scenario is kind of painting the picture for us. This is some sort of an explosion. So there's some mechanism here that was kind of fast. I mean, we're dealing with sort of pipes. There was a little bit of a crater in the ground. All these things telling me like, hey, listen, safety as always. Let's make sure we're paying attention to that there's not an additional secondary something that is going to happen while we're nearby where it originally happened that's going to affect us and our ability to give care. The ability to recognize also when you need additional assistance and anticipate that and getting that going, particularly if you're in the rural environment and you're like, hey, any other additional assistance we may call might be a little ways away. Get those balls rolling. So it's easy to send people home. But when you realize sort of down the road, hey, listen, we need more help and it's an additional 20 minutes away, then you want to make sure that you're also anticipating the need for additional assistance.
So let's review the rapid assessment that Regan has alluded to already. We've established that from an airway perspective, he is talking, he is protecting his own airway. So there's some question of debris and whether or not that integrity is going to hold. We talked about that from a vital signs perspective. Breathing rate was appropriate. Oxygenation's a little borderline. Breath sounds are present throughout, so that's reassuring as far as that goes. Pulse-wise, tachycardic, strong pulses in all four extremities. So airway, breathing, circulation, like we talked about. Disability, or your GCS in this case, is roughly 15. You don't really identify any focal neurologic deficits. And then E is our exposure, or in EMS, we think more about like just visualization itself. And I want to take a second to unpack something that's specifically important in the context of explosions. And I know Phil might have some background in this as well. But one of the things that we might mention it in medical school, but I feel like I got more of it in residency, is talking about blast injuries in general. And I think this is very relevant to the eye injury case. There are actually a total of 5 degrees of blast trauma. You've got your primary, you've got your secondary, you've got your tertiary, your quaternary, and then number 5 is quinary. There is actually, I didn't even know quinary was a word, but there's your 5th degree. So your primary is going to be mainly related to the blast itself. So things like a blast to the lung, eardrum rupture, abdominal hemorrhage, is an eyeball ruptured, for example. Traumatic brain injury might be a second one. Secondary effects are going to be things like penetrating injuries such as gunshot wounds, flying plastic. Again, penetration of the eyeball kind of falls into that secondary category as well. Tertiary refers to the injury to the body itself. So that's going to be fractures, amputations, open or closed organ injuries, blunt injury, crush injury, etc. Quaternary refers to burns. So anything that, if there was a flame component, a chemical component, did they inhale anything from the fire or from the gases in question? And last but not least is quinary, which is more so related to warfare or to acts of terrorism, in that we talk more about, is this a biological weapon? Is there any chemical exposure? Is there any radiation exposure? So those are essentially the big five. And I just want to paint this picture because just because we've got a clear injury to the eyeball, there's still so much more we want to make sure that we're assessing. So when Regan starts unpacking this more, that's why we want to think about this head to toe very thoroughly. Last but not least, that they do throw in there sometimes is just keep in mind that there is a psychological trauma component to this because the person was exposed to an explosion. So there's probably going to be some degree of PTSD that will need to be addressed down the road at some point. Now that we've unpacked these different types of trauma and related to blast injuries, Regan, why don't you unpack a little bit more what you would want to do based on that information, and Phil, obviously hop in as well with your thoughts.
Yeah, so in these cases like this, like Doc mentioned, there's a bunch of different things that are going on with it. We want to keep just our good basic care going. We want to make sure that we're managing some pain. We want to make sure we're giving oxygen if needed, preventing shock, all those things that we learn in our EMT or our medic courses. But additionally, starting to figure out what those injuries were. Yes, we have an obvious injury to the eye. Are our ears looking okay? Is there any fluid running out from them? Is there any obvious injuries to their head? Going on to any other penetrating injuries within the chest, within the belly, within any of the extremities, seeing if there's broken bones. And you'll be able to kind of tell how far a patient would have been thrown based on where that explosion happened if we, again, just kind of assess this scene. But taking the second to just squeeze every arm, squeeze every leg, see if there's any rib fractures, it helps just to get all of that information going here. And then if there's any sort of burns that are still happening and wanting to stop that process, like we've talked about before, or like we have in our burn protocol, when we go into that area 5 of those blast injuries, that's more of protecting our patient. If there's chemicals, we need to irrigate. If there's a radiation, let's get away from that source, and any sort of other agents that might pop up there. And this is where fire or police can be really helpful because they might know more information. Since you're focused on that patient, fire and police might be a little bit more aware of the scenario out there. So like Phil has said multiple times, just ask your team, ask for help, ask questions, because we need to just acquire all of these things on the scene so we can take care of the patient well, but also the emergency department knows what's going on because they don't get to be those eyes on the ground like our team does.
Yeah, information is huge. We're at some point going to call the receiving facility and tell them what we have. We're giving them the pertinent information so that they can prepare, get whoever that they need to get in, if that's going to take a little bit of extra time, but also kind of gathering supplies and then gathering information and seeing who all needs to be involved. For instance, and this is where I encourage everybody in EMS. Encourage everybody, be curious, talk and ask and just explore things and imagine an EMS scenario that would occur near a pool. Pools are systems that sometimes they have compressors, which means they can have water or air under pressure. They deal with chemicals. So sometimes you're dealing with chlorine, but sometimes you're dealing with bromine. Sometimes you're dealing with saltwater pools. There are different manifestations of chemicals and things that can be potentially blasted into somebody's eye, or that they could be exposed to or ingest, particularly if you're talking about pools and kids and summertime and that kind of thing. So getting the information and being curious about what is what and being able to sort of get that stuff quickly is key to being able to relay the information to a receiving facility and then being able to prepare. That's going to help your patient. So that's huge.
It is so cool that you know that, first of all. I did not know that at all, and that's such a cool nugget of information to take away from this, for sure. Assessment is done. You've done the head to toe. Mainly, you're seeing just all this plastic shrapnel on the face. Maybe some damage to the clothing, but nothing that penetrated into the chest, best you can tell. There's no bleeding other than maybe some abrasions and scrapes on his arms and his face, but nothing that's actively hemorrhaging. So nothing that you need to control per se. Next steps, Regan and Phil, what do you want to do? How do you want to get this patient stabilized? How do you want to get him into the rig? And then after that, we will transition over to a little bit of the pathophys and our protocol.
So based on what we're seeing on the scene, based on what we see within this patient, we want to transport safely, whether that is a C-collar or using a backboard just to transport out. But we want to get this patient removed from this environment. One, because we obviously need to get them to the emergency department, but two, we never know if there's going to be a secondary explosion or if there's continued chemical exposure. So we can safely move our patient to that gurney, again, getting that exposure going, taking the second, lifting shirts, rolling up pant legs, if they're able to help take off those clothing and just see everything that we need to see, and then cover that patient back up. Respect our patient's modesty, make sure that they're comfortable. I mentioned before, like pain management, this just seems like something that's going to hurt. And do not be afraid to give these patients pain medications. Whatever you can use on your rig. It will depend, of course, if you're ALS or BLS, but taking some of this edge off is really going to help with this patient to be able to communicate back. A lot of that shock factor comes in with some silence, and taking away some of that pain can actually help that patient to interact with you a little bit more. Additionally, an important thing that we'll talk about in here is not removing these foreign bodies if you are able to. Obviously, if these foreign bodies are ginormous and you can't move this patient without that, that's a whole team approach and something we won't talk about here. But this patient has this plastic piece in their eye that does not need to be removed to safely transport this patient, so we leave it. We try to shield it, and we'll talk about shielding versus patching, but really we just want to scoop up that whole little scene, bring them into the rig where they're safe, treat their pain, treat their oxygen status if needed, check if there's any other injuries, and especially in the rural setting, let's get en route. Because like Phil said, we could be 20 to 40 minutes away. We're not going to be able to fix this patient in the ambulance. We need to get them to that definitive care.
Yeah, zeroing in on just a little bit more of the assessment, focusing on the eye. I think it's important that maybe the last time you saw kind of a breakdown of the different parts and pieces of the eye, it might have been medic school or EMT school, and that's okay. We're not expecting anybody to be ophthalmologists after our podcast, but being able to sort of accurately use the same terminology to describe the injury that you saw initially, in case that by the time you get to your receiving facility, anything has changed, that's huge. So you probably should know things like globe and cornea and iris, and potentially like where the anterior and posterior chambers of the eye are. That way you can kind of describe, listen, I'm seeing some blood collection on the front part, or I'm seeing blood collection in the entire sclera. I'm seeing penetrating body going in basically right into the level of the cornea. That gives people, particularly over the phone, when they can't see what you're seeing, a really good idea of what you're considering. Now, we're dealing with obviously a foreign penetrating object into one eyeball, but that doesn't mean that the other eyeball can't be hurt. In the case that we are thinking about stabilization of a foreign body in one eye, we also need to make sure that we're not ignoring the other eye. So control, as the eyes move together, that control is huge. The other thing, too, is just in general, when you're looking at eye injuries, consider a couple things. One, you might see blood in the eye. You might see very clear foreign body like dirt or debris in the eye area. You might see a laceration to the eyelid itself. You might be able to sort of see all of these things and add those to your description of the injury while you're on the phone. Obviously, we're worried about foreign bodies. And then the thing with foreign bodies, particularly in the case of penetrating foreign bodies, is globe rupture, because that is detrimental to people's vision, right? So we want to make sure that if there is an opportunity for a foreign body to have entered into someone's globe, we want to be able to articulate exactly what it is that they were doing. In this case, we're dealing with some sort of an explosion and maybe some plastic piping and some chemical exposure. But if I change the scenario just slightly, and you may see this in the rural areas, right? We talk about high pressure injuries in terms of like compressed air. We talk about people working in machine shops and kind of side houses and barns and stuff where they may be subject to metal shards and the sort of spiny little pieces of metal when you're talking about cleaning metal. And if one of those spines were to come out, it might not be ultra obvious that there is an actual injury to the eye. They may have just felt something. It might have been a spark, but it could be a metal object that has entered the globe in through a really small entrance, and it's not particularly obvious now. So knowing what they were doing beforehand is huge, and then knowing the potential injuries down the road is also huge. So we're in town at the baseball game, and it's not a penetrating injury, but it was maybe a higher velocity injury to the eye. We should know that down the road swelling of the ocular area could potentially also affect someone's vision and could potentiate globe rupture as well. All of those things are basic level, surface level pieces of knowledge for you. And that way if you want to go and follow up on this stuff, I'm sure we can put something in the show notes. But if you want to just be a little bit more familiar with your eye injury, those are the pieces that we're going to be looking for on the receiving end to know exactly what's happening without ever being able to see it.
Let's get Marie into the mix here a little bit. Let's switch over to the pathophysiology. Let's talk about the eyeball, the important parts, why they matter, why we get really worked up about eyeball injuries. And Regan will tag team with her as they walk us through the general pathophysiology to be expected with the eyeball and trauma related to the eyeball.
Yeah, absolutely. As Phil was saying, we are not expecting anybody to become an ophthalmologist by the end of this podcast, but there are some structures to the eye that are important and we should try to know. If you're like me, you might find the vocabulary a little confusing, so we're just going to break it down and kind of go step by step through the structures of the eye. So starting out, we've got the bones, which make up the orbit. This is comprised of a bunch of different facial bones, essentially coming together to form that bony structure that the eyeball sits within. So when we talk about orbital fracture, we're talking about those bones that make up the structure where the eyeball sits. The eyeball itself, you've heard it already, we call it the globe. Covering the eyeball would be the cornea, which is this transparent piece of skin. If you hear us talk about corneal abrasion, we're talking about that thin, translucent layer of skin over the front of the globe. Behind the cornea is the iris, which is the colored part of the eye, and that's made up of the muscles that control the amount of light that enters through the pupil. So when we're talking about dilation or constriction of the pupil, those are the muscles within the iris that are performing that action. The lens is a transparent structure that focuses those light rays to form the image on the retina. And the retina is located on the back aspect inside the globe, and that is the sensory component of the eye, which converts the light into color and transmits that electrical image down the optic nerve. Behind that lens is a jelly-like substance. That's the vitreous humor, and that basically just fills the inside of the globe. The white part of the globe is referred to as the sclera, and the blood supply to the eye is delivered via the retinal artery, which returns via the retinal vein. The movement of the eye is controlled by a series of muscles that forms a matrix around the globe. When we're talking about extraocular movements, that is what is being controlled by those muscles.
Now, when we go into a pathophys side of it, Marie covered that physiology beautifully. And now when we go into that pathophys, things that can happen to the eye, any one of these structures can be injured. And like Phil was saying, it's really helpful to actually characterize what structures you are seeing damaged if you are able to assess that. So let's say in this patient, we can see that plastic piece going into the eye. Maybe it has cut that eyelid a little bit. We can feel around to see if there's any fractures on that orbit. Our patient would let us know by expressing extreme pain when you feel onto those. And you could be able to tell if that plastic piece has penetrated into that globe or the eyeball, not only going through that cornea, but possibly through that iris. It could come through that sclera. Anywhere in there where that plastic piece is just stuck and not falling back out of the eye, we should be concerned for a globe rupture. If at any point we see any jelly-like substance coming from around the edges of that penetrating object, that's that eyeball jelly, that vitreous humor expelling out. We know that that eyeball, that globe has been ruptured. We've been focused a lot on that penetrating side, but a blunt injury can still cause some pretty decent injury to that eye. You can still rupture your globe just from a ground level fall, and that was the case that I've had before. Fish hooks can get stuck in places and pulled right back out. You can honestly hit your eye on almost anything, and it's a pretty delicate structure. So always keeping it in mind, no matter the trauma case, just peek at those eyes again. The other thing that can occur that we've referenced in this case is a chemical injury, whether acidic or basic. Any chemical that goes into that eye that shouldn't be there is going to need to be irrigated out because it can strip away that cornea and penetrate deeper into those surfaces. And interestingly enough, radiation burns can absolutely happen to your eyes. This can be as simple as a sunburn on your cornea, and it can be an extremely painful thing. It sounds like I'm minimizing that when I say a sunburn on your cornea, but it really does scratch away at that surface and can affect your vision.
So when we're talking about assessing eye injuries out in the field, some red flags that you should be aware of. proptosis, which is the fancy word for when the eyeball is bulging out of the socket or the orbit, any protruding and or intraocular foreign body, which we've talked about a lot already, any gross deformity to the globe or the eyeball itself, absence of a red reflex. This is something you can check for using a pen light or whatever light source you have on you. An afferent pupillary defect, which is otherwise known as asymmetric pupils if one is dilated and one is constricted, or vice versa. Any abnormally shaped pupils, so sometimes you'll hear people describe a teardrop pupil or a blown pupil. Hypopyon, which is the fancy word for white fluid in front of the eye, which is essentially a collection of white blood cells, could be pus. Any sudden acute reduction in a patient's visual acuity. This can happen a lot of different ways. It could be described as a curtain coming down over their eye. It could be a sudden onset of blurry vision, which is another red flag, diplopia, double vision. So some things to watch out for when you're doing that assessment.
One more that I would add in there, we've talked about that white fluid in that anterior portion of the eye, which is that anterior chamber. You can also just have blood in any of these spaces, and that is abnormal as well. We're used to seeing eyes without an excessive amount of blood in them. So noting that if you see just a little collection of blood in that eye, or the white part of the eye is no longer white anymore, these are some abnormalities that you can also relate back to your receiving facility.
So we know what the eye looks like, what it's supposed to do, what the structures are made up of. We know what the concerning things you might see when you quickly assess the eyeball. The next question that is naturally raised is, what do we do about it? And specifically, what do we do about it from a pre-hospital setting? Because even in the emergency department, we're pretty limited on what we can offer. Like when it comes down to definitive reversal, you're needing either an optometrist who can do some basic stuff, or you might need the ophthalmologist that might need to do surgical intervention. But we got to get the eyeball there in one piece to start with. So what does that look like from the pre-hospital setting, Regan and Marie?
So in that pre-hospital setting, our specialty is kind of packaging up our patients all nicely and bringing them in. And this is no different case. We want to protect that eye from further injury. Like our case today, we have this giant plastic piece in the eye. We need to make sure that that doesn't move anymore. If that starts shifting around, we're just going to cause increased injury. So this is where we start with some shielding practices. And I vividly remember this from my EMT course, but they just handed us paper cups and some tape and went, go shield each other's eyes. And I had no idea what was going on. But the point of this is that you can use your little trauma shears, you can cut any sort of object, usually it's like a paper cup that works well, and just kind of stabilize that foreign body in that eye. You don't want to add more pressure, you don't want to pull that out, but you don't want this moving around as you're moving that patient. And the important thing is that this is different than patching an eye. There shouldn't be extra gauze pressed up against that eyeball because that will increase that intraocular pressure. We don't need to just stuff a bunch of gauze on the outside either, again, increasing that pressure. A little goes a really long way in these cases. So just trying to secure that, even having like that paper cup over that eye and that object and then tape down along the cheek protects it from any accidental bumping, from any excessive movements while we move our patient into the rig or out of the rig. And it just makes sure that we don't cause any more injury to a patient who is already going through enough.
Yeah, we cannot stress enough not to remove any foreign objects from an eye. This is very important, and we talk about it in the protocol, I think multiple times. Sort of the same with any penetrating injury to anywhere else in the body, you want to leave it where it's at. And like Regan was saying, get it stabilized so that you're able to transport. Something you can also consider doing, like Phil mentioned earlier, the eyes move together. So where one eye looks, the other eye looks. If you have a penetrating injury to one eye, but the other eye is mostly unaffected, you can offer to your patient to cover the unaffected eye as well. And what this does is it basically just prevents them from looking around with their unaffected eye, which would subsequently cause movement in the eye that has the penetrating injury. It can be a little uncomfortable for patients because you're essentially blindfolding them and they can no longer see what's going on. So it's super important to offer it to them and make sure you get their consent before you proceed with something like that.
And if that's the route we decide to go, increase that communication with your patient. If they have agreed to having both of their eyes covered and it can reduce that irritation with it, you will explain every single thing you're doing, because even when you have your eyes closed, putting on a blood pressure cuff can be a little nerve-wracking. So just keeping your patient informed on what you're doing, whether you decide to do both eyes or not. Now, shifting it a little bit, if it's not a true object in that eye or we can't see exactly what's going on, a real key thing with eye injuries is irrigation. We need to start flushing out either the chemicals or the little objects that are in there. And there are very specific devices that do this. I believe like Morgan Lens is one of them, but it's an expensive device that not many people have on their ambulance. So there are other ways to do this, including hooking up your nasal cannula to a bag of saline and just setting the nasal cannula right on the bridge of the nose. That fluid will just kind of drip through, and it'll just drip through the eyes and create a continuous irrigation while we get that patient maybe to a facility that has a better object, or they'll just keep using this handy device that you created.
I think this is especially crucial in the context of prolonged transfers, right? So if we're in the middle of nowhere, setting up this apparatus could be very, very helpful. But from the context of like, oh, the hospital's 2 miles down the road or a block away, then I would just argue on the side of if you've got some syringes of saline, if you want to squirt it in the eye, that's fine, but get them to definitive care instead. But definitely love that apparatus idea, especially for ones that it's a prolonged extraction or you've got a long transport time to get them from point A to point B.
Yeah, Regan and I were very excited about the nasal cannula with the saline, especially in the rural setting. We just thought it was so clever. But I would say secondary to don't remove the foreign object, most important rule number 2 of eye injuries is irrigation. You really can't irrigate an eye injury too much. So just if you can flush it as much as possible from as soon as you assess your patient all the way to the hospital and hand them off, it's only going to help them in the long run.
So we're all about the data here too. And we're all about getting a little bit of evidence-based medicine. And obviously, eye injuries in pre-hospital, especially in the rural setting, there's probably not a lot of data out there. But it does sound like you did a little bit of a deep dive for this as well.
I jumped in a little bit, and yes, it is fairly limited in the pre-hospital setting, but that doesn't mean that there isn't stats that pop up on eye injuries. And I thought it was just helpful to kind of put some numbers to this because, like we've been talking about here, we all have like 1 or 2 cases. It's not something we see often, but when we see it, it's pretty memorable. So I just want to put some numbers to it so that people are thinking about this and preparing for this, because you will see a case like it. It just might not happen as often as all these other calls we're used to going on. So focusing just in on the United States, approximately 7.5% of people will suffer some sort of eye injury, and the degrees of severity will differ greatly within that. But within that 7.5%, up to 6% of that can have visual impairment, and even another 6% of those can be partially blinded from those injuries. So these are usually very serious. Our eyes are very special organs, they're very delicate organs, and when we have injuries to them, the effects can be pretty dramatic. However, usually only about 0.6% of people who do experience eye injuries are left completely blind. And that is still a percentage that would make me nervous whenever I see an eye injury, because if that's something that I could prevent with good pre-hospital care, with quick transport, I'm going to make sure I can do that for my patient. Another stat just to throw is that there's approximately 2 million cases of ocular trauma each year. Usually only about 20% of these are actually hospitalized, but that does not mean that a certain percent of them aren't still having like outpatient surgeries or having procedures done in the emergency department. This can be a pretty massive effect on the patients. Now, who are the ones that are experiencing this? Unfortunately, eye injuries do not discriminate. It can happen at any age of life. It is actually a little bit more common in our elderly population, such as the case that I got to experience about a year ago with a patient who was just walking around an amusement park and fell on the sidewalk. Ground level fall, just happened to hit their eye. It can be as simple as that. Adolescents and younger adults, that's usually where we're in motor vehicle accidents or assaults. And that's usually when we see our ocular fractures happening. We want to make sure we're checking those eyes as well. And then when we get down to that children population, these are the sports injuries. This is the baseball to the eye, or when the baseball bat shatters and some shards go. I've seen a tennis ball to the eye, and that fuzz can be so irritating. But these eye injuries just do not discriminate. So always kind of keep it in mind on this. And if you're working in any sort of field that has a potential exposure, potential of chipping, potential of chemicals, home renovations, working in the garage, playing a sport, we'll just throw on some protective eyewear. And that's my little PSA. Just throw some glasses on. You'd be shocked how much those can help.
Anything else you should know about?
I really don't think I should talk about the pre-hospital lateral canthotomy.
Pre-hospital lateral canthotomy. Do we do it or not?
The medics do not do this. Pre-hospital physicians might if they see it indicated. I don't think we're going to see it very often, but I found some cases over in Australia with those prolonged transport times where they were able to get a pre-hospital physician from a helicopter to do this lateral canthotomy in the field. And in those extreme cases, it helps. I don't think this will become a pretty common practice, but it's nice to know that it is an option when we have those physicians out in the field.
So the Reader's Digest version, for those of you out there that are not familiar with the terminology, lateral canthotomy is basically making an incision on the lateral aspect of the eye near the eyelids, and you're trying to separate away tissue and cut a ligament to open space. So effectively, with these really bad blunt traumas where fluid is collecting into the eye or behind the eye and increasing pressure, this helps to alleviate that pressure. Generally speaking, as we've already said, this is something that can wait till we get to the hospital. It's very rare. Usually if it happens in a level 1 or in residency, there's like 30 people in the room because you never get to see it that often. And generally ophthalmology is going to snipe it because they like those. But it's good to know about it, that there are ways that we can evacuate the pressure. And it's good to know that in some settings like Australia, you can maybe fly out an EMS physician and maybe help with that. I have not heard of any of our EMS physician colleagues in Minnesota doing it. I would love to hear if they had, because I think that would be absolutely awesome to hear about, like in the field. But I digress. Let's move on to the protocol itself. Regan has been doing protocols for us and working through protocols with me for a number of months now, but we're getting Marie into the muck a little bit, learning the process and how we write these up. And so they kind of tag team this one, and I'm excited to hear what you came up with and what we're trying to finalize for our protocol for eye injuries.
Yeah, I would say for my first protocol that I got to help Regan out with, it was definitely a fun one, a very interesting one. Eye injuries aren't something that you think about very often. It's not something you see all the time. So it was a bit of a learning experience, I think, for both of us to kind of brush up on the common practices. And this protocol was a little bit different in that the interventions that you can do are a little more limited in the field. And it was more about the key considerations, the things that you want to keep at the front of your mind when you're dealing with these sort of cases. We've said it a bunch already, but we'll say it again. Do not attempt to remove any foreign bodies from the eye. I think we have it written multiple times in the protocol, all caps, bold letters. Don't do it. After that, early transport is essential for effective trauma management. That's the case in any trauma, but especially with an eye injury, considering what we said earlier about how these people most often need intervention from an optometrist, an ophthalmologist. There's just not a whole lot we can do for them in the field, so stabilizing their injuries and getting them transported as soon as possible is the best course of action. Phil and Regan mentioned this when we were going over the case, but assessing for other injuries, eye injuries are very dramatic. They are very distracting and typically resulting from some sort of trauma. So we want to make sure that we are still doing a full assessment of the rest of the body, an assessment of the environment to make sure the patient is safe, to make sure that we are safe. So making sure that we don't get overly distracted by a large penetrating piece of plastic in the eye of a guy who is trying to fix his pool. Not putting pressure on the eye, another very important point that we mentioned earlier. This is something you should really consider, especially when you're shielding the eye, to be very delicate. We don't want to add any increased pressure. We don't want to increase the risk of us worsening the injury to the eye. Like we said, they're very, very delicate organs. So just making sure that we are delicate in our management.
Another interesting point that we wrote out within the emergency medical care in this protocol is attempting to remove any contact lenses that are in patients' eyes, especially when it comes to a chemical or radiation injury to the eye. That contact lens is just creating an environment that is not easily accessible by that irrigation. So if you are able to take just a little saline flush and flush that contact out of their eye, or if the patient is able to just simply remove that, it can help with that proper irrigation, especially on those longer transport times. As we've said before, nothing needs to be forced in or out of that eye. If you can't get that out with an easy flush or a patient's flick of their finger, leave that contact lens in, but please make sure you tell your receiving facility that you have found a lens in their eye. That's an important factor that goes along with the treatment inside the emergency department. The other part of the protocol that I just wanted to reference because we talked about it in our case is proper pain management. And basically in this protocol, I say to refer to our pain management protocol, but it's important to remember that this is going to be a painful injury. So treating with some acetaminophen, some ibuprofen, or if you're up at a more well-stocked facility, you can do some of that Toradol, that morphine, that fentanyl, whatever your service area uses for that pain management. Go ahead and make sure that we treat these patients well. In addition to that, we talked about how these injuries can cause some double vision or some blurry vision that can create some nausea in our patients. So don't be afraid to treat with some antiemetics as well.
From there, whatever else you're going to do really just depends on the cause of the injury. So trying to take those cues from your environment, the history from your patient that you can get or any witnesses to identify the cause. If you have chemical injury, you're going to irrigate, like we discussed before. Any globe injuries with a penetrating object or without, you do want to shield that eye just to prevent any manipulation of any foreign objects. You can consider covering the opposite eye to prevent movement of the eyes with the patient just looking around. And if you have any small foreign body, sensation of a foreign object, something that's a little bit more minor, just think about protecting the eye. Maybe try to avoid any direct contact with a Morgan lens, but you could do a little bit of flush with some saline and then transporting for appropriate exam and removal in your emergency department. One final thing to kind of keep in mind, if your patient is requiring an intubation for any reason, you want to try to avoid ketamine or succinylcholine if you can. These medicines can increase your intraocular pressure. So just something to kind of consider if you're thinking your patient might need an intubation.
Very thorough, very well put together. I love it. One of the actions we're going to be taking, hopefully over the next few weeks, is we're going to try to get our website updated. We're hoping to get our protocols or some examples of the protocols up so that if those of you out there in the sticks need some guidance, you're welcome to take a look at them. You're welcome to copy them. If you've got follow-up questions, please don't hesitate to reach out. But obviously, rural EMS is absolutely a team sport, and I do not want people out there reinventing the wheel if we can be helpful. So if you want to take a look at ours at any time, we'll have them on the website. Ask questions. Obviously, that's what we're here for, is just to educate and help you to provide better care for the people in your communities. We've got protocol part covered. Let's go back to the case to wrap this up. Let's talk a little bit about what that's going to look like in terms of final definitive care. Regan and Phil, take it away.
Yeah, just some pearls on my end while we're kind of wrapping up what we wanted to do. We've talked about protecting the eyes. We've talked about not removing things. We've talked about assessing the situation and getting as much of the story and all the questions answered so we can transfer and relay like a really good story. Another thing to add, if you can, is get that person's like initial visual acuity before you wrap it all up. So you can see if there's a change from the time you pick them up or their baseline level of visual acuity to the time you drop them off. Since we're dealing with these sort of extended transport times, that's one of the pieces of information I'm sure the hospital staff is going to love to know. Another thing, too, that we might run into, and we often run into in EMS, and I'm sure rural EMS, I'm talking to the first responders and I'm talking to the basics and the folks that are out there, you know your population of patients. And you might get people who are like, you know what? I'm good. You know what? I'm fine. It's no big deal. I'm fine. It's fine. It's fine. My two least favorite words when I'm trying to assess somebody is it's fine. Okay. They are convincing themselves and they are hoping that you will help convince themselves that more care is not needed or more assessment at the very minimum. But one of the things to keep in mind is that foreign objects in the eye can be prone to infection. And so while they may not be having a right now type of problem that they think is, kind of going to go away on its own, they may be prone to infection. So they may need antibiotics and they may need a booster on the tetanus shot. Those are the things that you want to make sure that you're advocating for and that you explain to people so that if and when they finally do actually want to refuse care, that they are doing it informed of all the different parts and pieces that are at stake here. Another thing, just for when they're in the back of the ambulance, head of bed at 30 degrees is a little bit helpful. Just keeping that intraocular pressure down as much as you can, as well as Regan mentioned, the antiemetics, the Zofran, as we refer to it on the rigs, but the ondansetron, to make sure that we're not having these folks need to retch or vomit, which would, like we talked about, increase that intraocular pressure as well.
Additionally, we talked about this at the beginning of the case, but there's some psychological damage that can come with these injuries. Keeping our patients nice and calm, explaining what is going on, especially if we are going to be covering one or both eyes, their perception of you in the back of the ambulance will be skewed, and you want to make sure that you're explaining everything that you're doing and continuing to talk to your patient, not only to calm their nerves, but so they can track you in the back of that ambulance. I wouldn't want to surprise a patient from behind in the captain's chair, having not spoken to them for a while, and have them jerk around because I scared them and they have this piece of plastic in their eye. So just continue to chat with your patients, explain what's going on, explain how far away you are, and asking any additional questions for that assessment, not only to keep them engaged in it, but to keep them a little bit distracted from what is happening.
So we'll treat this as an oral board. You're about getting to that cutoff of these are the final things that you need to do to pass this case. So we've got him in the rig. What are your final steps before you get him transferred or get him over to definitive care?
Anytime we bring our patient back into the rig, we reassess, making sure our airway, our breathing, our circulation, our disability, any exposure is checked one more time. Anything that needs to be corrected is. But for our patient here who is really just experiencing that eye injury, at least for the sake of this podcast, shielding that without extra pressure to that eye. If we do think that there are any chemical exposure as well, getting some of that irrigation started, whether it's just some saline flushes or our nasal cannula makeshift device, keeping our patient nice and calm, keeping that head of bed elevated, and continuing to assess not only changes to our patient's mental status, to their breathing, to their circulation, but to the eye as well. Continue to frequently look at it, see if that pupil is changing, if their vision is changing, if we're having an increase of blood collection. And of course, last but most importantly, I would say, is letting your receiving facility know what's coming and how far out you are so that they can better prepare for that patient in their emergency department.
Yeah, I do like having a heads up when I can get one. So a phone call or just a discussion with the charge nurse is always appreciated so we can prep accordingly. All right, so we're wrapping things up here, but I'd like to turn it over to Phil one more time as the only acting medic in the field these days. Phil, what are your three? You get three of them. What are your three takeaways from this discussion today, which is full of incredible nuggets all around? But give us Phil's top three of what, if anything, that you could walk away from this. What are the three big things that I want you to know?
Take control of your scene. Make sure that you're controlling the pace. As soon as you arrive, if you're adding to the chaos, then you're not really helping. The reason that they call professionals is so that we can take control and actually manage what is happening. Slow it down so that you can get the information you need to best help your patient. 2, huge on the pain control. The better you're able to manage someone's pain, the better you're going to be able to assess them without them writhing around. And there's really good evidence for downstream PTSD psychological effects from having something traumatic happen to you when we control the pain. The brain just doesn't remember it the same way when we're able to really control that pain and make a kind of a really bad situation at least marginally tolerable. Maintaining that pain control, reassessing and making sure that their pain is a priority in addition to all the other things that we're doing in the ambulance, huge. And then the third thing is making sure that your assessment is thorough. You're transferring and relaying good information to the hospital in a calm manner, in a clear way, using the right terminology whenever possible. And additionally, that at the very end of it, you are doing your documentation. Everything that you do needs to be written down and documented and made sure that you can answer for it a year from now if something comes up and you're questioned about your run. You want to be able to look at your documentation and your narrative and go, yeah, I did assess his visual acuity. Yes, I did ask what his baseline visual acuity was. Yes, we did control for pain. Yes, we did set up irrigation. Yes, if available in your rig, yes, we did apply topical pain control like tetracaine or something like that. So you want to make sure that all your documentation is correct, that all your doses are correct, that all of the things match, and that your reassessments are put in there, particularly when you have those extended transport times. You don't want to be sitting behind somebody doing paperwork and then 20 minutes has gone by and you haven't asked them anything. So those are my big three. There you go.
Phil Aguet, firefighter, law enforcement, medic, also recently graduated nursing student, soon to start doctorate program for nurse practitioner, just a man that does it all, knows it all. We have got now physician Dr. Regan Washist. So proud of her and all the stuff that she has done. It's been a pleasure having her here, and I think she's going to be hanging out with us for a while still, even though she's got more commitments. And the newbie, Marie Tate, she's going to be hanging out with us for a while. I love it. We're very thankful to have you here. But as a form of hazing, initiation, we're going to have you, Marie. We're going to have you send us out today. Can you please finish with our signature tagline?
Well, thank you, Dr. Collins. I'm just so excited to be here, and I look forward to doing more. May your mayhem be well-controlled, full of teachable moments, but also provide you with the opportunities to provide your patients with the best care possible.